Alrighty, so we're right on to 30, so I might kick this one off. We do have a small group on today, but thank you to anyone who has dialed in. I do understand that COVID is just dominating everybody's lives at the moment, so it is kind of nice just to focus on something a little bit different. So my name's Amy and I'm the Clinical Training Coordinator for Point of Care Testing with New South Wales Health Pathology. My background is nursing, and today I've just got hopefully a quick little session just on the collection side of things. When I go out and spend a bit of time with clinicians in facilities, there's a lot of questions and a lot of regular questions that I get asked around the collection side of things. So we're going to touch on those today, and just some tips, some tricks, things that I've learnt in my time as a training coordinator as well. There's there are some people who do like their attendance recorded on My Health Learning, and so I've popped up a few ways that you can do that. There's a QR code there, but that doesn't work for everybody. So what I've also done is pop down my mobile number there on the screen, and I'll bring it up again at the end, but you can just also text me your name, your staff link number and the facility that you're from, and I'm more than happy to register for you on My Health Learning. So we'll just jump straight into it. So firstly, just acknowledging the traditional owners and custodians of the lands on which we work, and pay our respects to ancestors and elders, past, present and emerging. I'm on Wiradjuri country and I am a proud Wiradjuri woman. And let's get straight into it. So today what I really want to do for you guys is just cover the basics, the basic must-dos of collection in point of care, because there are some differences than in the lab space. Collecting from an IVC, so your intravenous cannula and your invasive lines, collecting via Venepuncture, and just some tips and tricks for better and easier results. So the first thing I always like to touch on, and if this is not your first rodeo here with me and you've dialed into a session with me before, you know that most of my sessions start with this, and it's just reminding people of the basics when running your point of care and collecting your point of care. Is just remember that there's a few things we need you to make sure you do every time, and that's just always making sure that you're using our point of care PreHybridized syringe. Now that, depending on where you're dialing in from, that's going to look different in every LHD, so you might just want to check with your super user or your coordinator about which is the syringe that you're using, but it needs to be the one that's allocated to that device and PreHybridized. It needs to be filled appropriately. It's very easy to get in the habit in point of care of thinking, well, I only need a drop for testing, so I'm just going to collect a drop. That becomes an issue, because if you've got too small of a sample, you're going to have way too much heparin from that syringe in there, and you've got that inadequate ratio of blood to heparin. And we have seen that affect results. If you're dialing from a rural and remote space and you have an ISTAT and you run troponin, we have seen that underfilling of the syringe lead to, in particular, false positives on your troponin. Number 3 is just make sure that you're always removing the air from the syringe prior to mixing. I don't know if it's a nursing or something that we get in the habit of doing a bit, but often once we collect the blood in the syringe, for whatever reason, we pull the plunger down a little bit more, pop the cap on, and then we mix. The issue with that is you've just introduced a little bit more air into that syringe that you've now mixed through your sample, and this can affect your gas results. So just making sure as soon as you've collected that you do expel that bit of air, making sure that you're mixing your syringe well each time you run a test. So that's particularly important on the ISTAT, where you could be running up to three or so cartridges. So just making sure that, yeah, we're really good at it. when we're walking to the device and we're mixing it for the first time and we're about to put our first test on. We're not so good at when we sit it down, we walk away because we've got a few minutes to kill, right, before we've got to come back and run the next test. We're not so great at picking that syringe up and remixing. And just making sure you expel 2 drops of blood before each test you run as well. And that's just being mindful of the fact that those tips of those syringes, a lot of them don't have that pre-heparinized coating right at the tip. So it can be a thing of there just being little microclots forming, and our devices do not like microclot whatsoever. So by pushing out a couple of drops, you just ensure that the sample that goes onto the iStat is a heparinized sample. It also, those 2 little drops just help to also get rid of any last little bit of air that might be sitting in that tip. So that's just a reminder of the basics. But we're going to jump straight into it. So when you're collecting from your IVCs, so from your cannulas and also from your other invasive lines, now just bear in mind I talk about Western New South Wales LHD in these slides purely because when this education was created, it was for Western. So it might be, you will just have to check with your area of what syringe you're using. But some syringes are a are a Luer lock. So they will attach directly to the cannula, to the bung of the cannula, which makes life a lot easier. When I was down in the metro space not long ago, though, a lot of those guys work on a slip tip heparinized syringe, and a little trick that a few doctors have taught me is if that you do pop that slip tip into the bung and you turn it even just a quarter, it does tend to lock that syringe into that bung and let you draw that sample out. The next thing just to remember is that a lot of people get a bit concerned when they're collecting from IVCs that the bung itself on the end of the IVC is going to cause hemolysis. That's not the case as long as you've popped that syringe on properly to that bung. The bung itself won't cause hemolysis. We as the clinicians are the ones who end up causing hemolysis, and that's because we've usually used a cannula that's a little bit too small to be taking blood from, or maybe that cannula is sitting in a really tricky spot and we have and it's just not, that blood flow is just not going to come out easy. So what do we do as nurses and clinicians? We basically swing off the end of the plunger and we really pull on that plunger trying to get that blood out, and that slow forceful draw, this is what causes hemolysis. At the end, I'm going to show you a little trick. If you're concerned about the bung in your facility, I will show you a little trick at the end of this presentation. Very, very simple way you can check that the bung you're using in your facility isn't going to be a cause of hemolysis for you. Now, the last thing I always stress to people is just to check with your local cannulation policy in your LHD as to what their rules are around drawing from lines. So for example, I sit here in Western New South Wales and our policy is a bit wishy-washy. It says blood may be drawn from a PIVC directly after insertion only, unless the PIVC has been inserted for the purpose of blood collection. So there, it is well worth just going and having a look at your guidelines and seeing what your guidelines state in terms from IVCs. So from a brand new line or IVC, it's just a case of attaching your syringe directly and just doing a slow, nice draw, not persevering with it. If it is giving you a bit of grief and it's not flowing nicely, you are going to end up with quite a hemolyzed sample if we do persevere. And for an IVC or an invasive line that has had fluids or medication running through it, just remembering to do your draw and discards. Every policy is different in the LHD, depending on what LHD you're in. Most are around, I've seen that 5 to 8 mils. So recommending in an adult patient about a 5 to 8 mil draw and discard of blood before you collect your sample. And that's just to limit that chance of the contamination from a drug or from a fluid that you've had going through that line. I've noticed that some ICUs now, they definitely, it's been a while since I've worked in ICU, but we definitely didn't have these, but there's now arterial lines and things like that that allow you to do that draw, but you don't actually have to discard it now. You can return that blood to the patient once you've collected your clean sample. So it's all about just getting familiar with your lines and your policies and what's working in your area. The other, I've already touched on this. So the no-no for IVC collection is just persevering with your difficult ones, because you are going to hemolyse your sample. The other big no-no, and this is the one we're all guilty of, I definitely am guilty of this in a past life and working on the floor, is collecting into plain syringes and decanting. So in point of care, we're absolutely against this. So we're against the whole collecting into 10 to 20 ml plain syringes, then decanting into tubes, and then particularly decanting into your point of care heparinized syringe. Now, the reason we're so against it in point of care is because it only takes 10 seconds before the blood in a plain syringe without that heparin starts to form microclot. Those microclots, our devices are incredibly sensitive to them, and it's where we are seeing issues in the results, and we do start to see some erroneous results. We see the machines kick off results, they won't run samples, things like that. And a lot of it is down to microclot. It's come from us collecting into these plain syringes. So I've got a little bit of a case study here for you. This is one that happened just not too long ago out in the far west that was really, really interesting. This woman was, from memory, early 40s, known type 1 diabetic, came into the facility. This facility uses a gem analyzer, so it's quite a big, for those of you who work on smaller handhelds, this is, I call it the iStat on steroids. It's just a much bigger device. They took their first sample on her and she had a potassium of 7.5. Now, some people were initially concerned that this was due to hemolysis, because if you hemolyse your sample, you will see quite an increase in hemolysis. But the staff were actually quite convinced that this was actually an accurate result. And the reason they were happy with that is that the collection had been very simple, straightforward. There'd been no issues with the lines, nothing. So they've had this 7.5. They've started to treat her for her hypokalemia. She got some Actrapid. I think they popped her on some Ventolin, calcium gluc, the works. And as you'll see here, they were taking quite regular bloods for her every couple of hours. And you can see here that she was responding really well to the initial treatment. 5.8 down to 5.1, so she is slowly coming back within range. And only 81 minutes later, and no change in her condition, she's still just having regular treatment, her potassium drops into its boots. You can see there 1.6 and 1. And this is only, like I said, 81 minutes later. And we're thinking, wow, what's going on here? These nurses, I think she might have been she's either in ED or ICU at this point, I'm not 100%. But they've taken it again because they were a little bit suspicious, only half an hour later, and it was back up to 4.5. Now, nothing has happened to this woman in this time. She's pretty stable at this point, just receiving her treatment. But this is what happened. She had a dilution of the sample with IV fluids. So what had happened is that sample that was collected there, where it suddenly plummeted to 1 and 1.6, the the sample that had been collected with running IV therapy. So how did we know that? Obviously, first, that rapid drop in that potassium piqued our interest. The hemoglobins also went through the floor, so they got really washed out. She wasn't bleeding from anywhere. She had no hematemesis, no melena. So that rapid decline also was a big hint for us, as well as the ionised calcium also just suddenly dropping right out. And the big telltales were this: the sodium was suddenly elevated, and so was the chloride. And the final piece of our puzzle was a brilliant nurse that did query as to whether it was a dodgy specimen, and that's exactly what she wrote in the notes. So this is a direct copy and paste from her notes. So what had happened for her is they had IV therapy running in the forearm of this woman, and they had taken the blood from above, up in the cubital fossa. So, and unfortunately, they couldn't stop the IV therapy. In an ideal world, you would stop the IV therapy for about 10 minutes and you would collect the blood sample. Unfortunately for this woman, she had a lot going on. She had stuff in both arms, lots of therapy running, and it wasn't an option for these guys. But as you can see here, this nurse, what she's done here, if you read her notes, she's queried that it was from taking the sample from above the running IV therapy in the forearm. She's swapped them round and put the IV therapy into the cubital fossa, taken the blood from below that IVC site, and then she got that better result, that came back up to 4.5. I guess the take-home message for here is a couple of things. The first one is to be aware of how IV therapy can influence your results, and it doesn't have to be as drastic as this. We have seen paramedics bolus 250 mils of Hartmann's, and a nurse just forget to do a simple 5 to 8 mil draw and discard from a cannula before getting a sample, and we've seen that affect lactate levels. But the other take-home message for this is, with this woman in particular, if you have no choice but to collect from a limb that has running IV therapy, collect from below the running IV therapy. And that was really evident in this case study when she swapped the lines around and she collected from below where that IV therapy was running. Collection via Venepuncture is the other one I want to talk about, because this is where it gets tricky, and this is a really big question that I get asked, particularly in more smaller sites, and it's, Amy, what do I do when I've got a patient that I cannot get a cannula in, but I need point of care? I need some point of care, but you know what, I also want to pull off some blood tubes for lab testing as well. So in this situation, your equipment selection is going to be really pivotal in ensuring that you are clinically safe when you're collecting the blood, but also that you've got a quality sample for testing on your point of care device. You'll see in the picture here that I had a few different methods here, but if it's point of care that you want, you're going to basically be left with a butterfly as an option. The guy on the right, the Vacutainer system, if you've ever tried to collect point of care by that system, you know it doesn't work because you cannot physically pop that syringe up into that Vacutainer. And of course, we're not promoting the use of plain syringes. So your option is going to be in the middle with a butterfly. And if you only need point of care, here's what you're going to do. Now, depending on your facility, you're going to have two types of butterfly floating around. You'll either have the one that has the spike on the end, like my blue butterfly there on the right, or you're going to have the product that doesn't. If you have the product that doesn't, it's very easy. You're just going to attach the point of care syringe directly to that butterfly. But if you do, that's going to have to be removed before you can collect your point of care. So it just depends on what you have in stock. And I'm going to show you this. I'll pop the PowerPoint down in a minute and we'll do a little bit of hands-on stuff. So this is where you just attach directly if you just need point of care. So you attach your syringe directly to the butterfly and you draw out your sample. Same rules apply. Please don't pull excessively on the plunger if you're not getting good flow. You're going to hemolyse it, end up with erroneous results. Digging around for a vein, excessively digging for veins is also going to end up causing erroneous results, in particular again, hemolysis and falsely elevating your potassium levels. And just always remember to still collect an adequate amount. Where the drama comes in is when you need your point of care sample and you need some formal pathology, so you want some tubes to send to the lab. Crazy techniques happen here, and again, I'm not shy to tell you that I've been a culprit to these in the past, and I've been there and I've done that. The most common ones we see is people just attach a 10 to 20 mil directly to the end of the butterfly, pull out a decent 10 to 20 mils of blood and do a decant into whatever they need. The other one that I see, and this is the messy one, we see people kinking off the end of the tube and just swapping between what they need and trying to kink the end of the butterfly. Blood kind of slowly drips out. It's messy. Infection control would have a field day with you if they came across you. That type of thing. So this is what I'm proposing. Next time you need point of care bloods and you need laboratory testing as well, stuff to send to the lab, this is the equipment that I want you to grab. I want you to look for the Lure Lock access device. The one that's usually floating around in nearly all New South Wales facilities is the BD brand. He's got the blue cap on the top here. I have also seen him floating around with a clear purpley top. Grab your butterfly, grab a bung, grab your point of care PreHybridized syringe, grab your tubes, and I also grab a little bit of tape. Then what I want you to do is take that lure adapter off the end of that butterfly, if that's the brand that you're working with, and I want you to pop the bung onto it in its place. Then what you can do is you stab your patient. This is where I find it easier once I've stabbed my patient with my butterfly, this is where I find it easier to just tape the wings down lightly. It gives me both hands to work with because there's a lot of stuff I've got to do now. So once you've done that, you can grab that BD Lure Lock access device and you can attach it directly to the bung. From there, you can collect your pathology tubes. And then after that, you can take that off and you can collect your point of care syringe for testing. The really good thing that I like about this is that it keeps the system closed. So you're not exposing yourself unnecessarily to the patient's blood. It is quite a simple and easy way to collect the sample. The other big question that I get asked is, what I might do, guys, I'm just going to pop. All right, I've just popped everybody on mute there just to eliminate that background noise for a couple more slides. I'll unmute you all at the end. A couple of questions with this is, Amy, is there a difference between, do I have to collect the lab testing first and then the point of care, or like is there an order of draw for which one I collect? There's not. For me personally, in a small facility like where I work, I choose to collect my point of care first, and that's simply because if I blow that vein halfway through the collection of that sample, at least I've got some blood to test here and potentially figure out what's going on with my patient. I don't have the luxury of a lab to send anything to. In other facilities, especially those that have a lab on site, they actually prefer to take their lab testing first and then their point of care. The only time that there would be a set rule for what you collect first is if you've got a septic patient and you need blood cultures. Blood cultures will always trump anything else that you do in this instance. So, we've talked about the benefits. What I might do is I'm just going to pop this down here, and sometimes I find, I might unmute if anyone's got any questions. Sometimes I find people find it easier if they can actually see what I mean. So this is my butterfly that I work with here where I'm at. I would be taking that lure adapter off, and please be careful when you do that. Underneath that rubber is a bit of a spike, so it is clean, but still nobody likes to get stabbed. Take that off, dispose of it in the sharps. Grab your bung. Okay, which I should have got out earlier by the looks of this. Grab your bung, pop it on the end. So now you've got that nice closed system. This is where then you would do all your normal prep. You would pop the tourniquet on your patient, swab, clean the site, whatever. Then for me, I'm going to choose, let's say today I choose to do my formal pathology first. Stab my patient, tape it over, grab my lure lock access device, attach it to the bung, and then I can grab the tubes that I need, and I can collect my tubes. Okay, then I can take that off. I can grab my point of care syringe. I can now attach it, and I can draw out my sample for my point of care testing. Grab that. Happy days. Take my needle out, and we're done. The last thing I just wanted to show you, I told you all that I'd show you a little trick if you were concerned that maybe your bung, whatever bung you're using in your LHD, might be causing hemolysis. If you ever want to check that and make sure, just grab a plain syringe, 5-10 mils, something like that. Grab a bung. What I want you to do is just take this plunger out of your syringe, of your plain syringe. I then want you to attach that to the bung. And then what you can do, and there's no way I'll be able, it's too tiny to be able to show you over a camera, but what you can actually do is then look through both ends, and if you can see light coming through from both ends, then you know that that bung is not going to be a problem, that blood's going to flow through there nice and easy. If you pop that on and for whatever reason you cannot see through, or it's partially obstructed, then you might have an issue. One of the reasons that we often find a partial obstruction when you're looking through there like that is that sometimes we just accidentally don't screw our syringes onto our bungs properly, and that's relevant in point of care as well. So that could cause hemolysis. But that's about it, guys. So just really recapping from that is just to remember to always just follow the basics. So I call it syringe etiquette when using your point of care. So using the point of care heparinized syringe, filling it up with enough, mixing it well, expelling air, expelling 2 drops of blood each time before each test. With IVCs, brand new IVCs, great, you can just pull the blood straight into your heparinized syringe. But for anything that has had fluids running, please just make sure you do a draw and discard before you collect your sample. And being aware of those contamination risks and questioning the results like that hospital did with the case study that I showed you. With Venepuncture, again, just making sure that we're not collecting into plain syringes, that we are always using our point of care heparinized syringes, and have a go. Have a go at creating a closed system like the one I've just shown you, and see what you think. It is a bit of a change in practice, and we're not always open to changes in practice, but I promise you it won't take long to get the hang of. Any questions before we wind that up for today? Awesome. If anyone thinks of a question later, or they've got a question that they don't want to ask me in this open forum, which I can completely understand, you can just contact me, amy.sutherland, or just reaching directly out to your coordinator, and sometimes I find that's the easiest way. Reach out to your coordinator and they can link me in with you. But thanks very much. Have a good afternoon, everybody, and stay safe.